Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar was entitled Perspectives on State Health Workforce Data Collection. It was presented by Danielle Weiss, Mary Lou Brunell, and David Armstrong on December 12, 2017. Hello, my name is David Armstrong, and today we have 3 presentations. I'm going to begin by providing you with an update on our state health workforce data collection inventory. And then Danielle Weiss from New Hampshire and Mary Lou Brunell from Florida will discuss health workforce data collection in their states. Now, after the presentations, you may ask questions using the chat panel on the right of your screen. Make sure you send your questions to all panelists to ensure that they have an opportunity to be answered. Also, when the event ends, you will be directed to a short evaluation survey. So please take some time to give us your feedback. We'd be very appreciative of it. And so let's go ahead and get started. Well, as many of you know, we have a state health workforce data collection inventory on the Health Workforce Technical Assistance Center website. Before we jump in there, I want to first give you a little bit of background. As many of you know, there's been a growing interest in developing state health workforce data collection and monitoring systems in recent years. And this was driven in part by healthcare reform initiatives at both the state and national level. There's basically, through these initiatives, there's been a need to better understand the supply and distribution of health professionals, to assess the adequacy of the primary care workforce, and to understand the relationship between access to care and health workforce availability. In 2015, HWTAC launched an online survey about state health workforce data collection activities on supply data, demand, and the education pipeline. And this survey forms the basis of our state health workforce data collection inventory, which is located on our website at healthworkforceta.org. And we're actually pleased to say that we recently updated the website to include a more functional map and improved state web pages. So next, I just kind of want to give you a couple screenshots, and I'm just going to do screenshots because we have a lot of information to cover today. And this is the new front end of the Health Workforce Data Collection Inventory on our site. And as you can see, there are now a number of filters on the web page which allows you to filter what you see on the map. So for example, if you're just interested in physician supply data, all you have to do is click on the physician box under supply data. On the other hand, if you're interested in supply data on, say, physicians and RNs, you can click on both of those boxes and it will show up on the map. And so we're actually very pleased with this increased functionality on the front of the web page. Now, the actual state web pages have been enhanced as well. And here we see an example. It looks like it's the Oregon Center for Nursing. This is one of the state web pages. So, of course, this is for Oregon. And on these pages, we list the different organizations and the types of data they're collecting. So we have a short description, a contact, and in this case, we actually have an example of a health workforce survey, specifically a nursing recruitment survey. And this is something we've been increasingly doing lately, as we have been adding examples of health workforce surveys to the website. Because I know one of the first things we're always asked when people come to us and start talking about data collection is, well, do you have any examples of surveys for whatever professions they're interested in collecting data on? And as you can also see scanning the site, it also gives you a lot more information on the type of data that's being collected. So here you see, at the top then you have workforce supply data, but if you go down below, you'd see workforce demand and the education pipeline data as well. The question is, well, today, what have we learned about health workforce data collection activities that have taken place in this country so far? Well, to date, 47 organizations in 36 states have indicated that they collect health workforce supply data. And just to be clear, every organization that indicates they collect data actually does collect supply data. That seems to be the basis for data collection activities. And so who collects workforce data? Well, there's actually a variety of different organizations. Primarily, we're looking at state agencies, state universities, nursing workforce centers, which we have one featured here today, and AHECs, that is Area Health Education Centers. Another question we ask on the survey is, well, is data collection for supply data mandatory? And as you can see via this figure, in 11 states, data collection is mandatory for all health professions. And then in another 5 states, it's mandatory for some professions. So for example, in New York, data collection is mandatory for NPs, but not for RNs. And so each state does operate a little bit differently in that capacity. And as far as the professions which tend to be mandated for their data collection, well, it tends to be physicians and the nursing professions. That is, in 12 states, there is mandatory data collection for physicians, and another 12, there's mandatory data collection for NPs, 11 states for RNs, 11 states for midwives, 10 states for LPNs, and then 10 states for dentists. And as far as demand data and the education pipeline data, well, fewer organizations collect data, these types of data. So only organizations in 18 states collect health workforce demand data, and organizations in 21 states collect health workforce education pipeline data. And with that said, that's kind of my brief update on the data collection inventory for you. With that said, here's the link to the inventory on our webpage and also to the survey itself. Also on the front end of the data inventory page, there's a PDF you can download, which is a report on different data collection activities that are taking place in the country. And for that matter, we are intending to update that report, I'd say within the first few months of next year. So it's something to look to. It basically summarizes all the activities, et cetera. Here's my contact information. If you have any questions in regards to the data collection inventory, please feel free to reach out to me. I would love to hear from you. And another thing I would like to ask as well, and I'll just put this throughout the whole audience, is, well, we've launched our data inventory in 2015, and we really haven't updated the questionnaire since then. So if you have any other ideas once you've looked over the data collection inventory, or any thoughts on what other types of information you'd like to see included in it, please let me know. Feel free to reach out to me and contact me. With that said, we're going to go ahead and move on to our next presenter. Our first presenter is going to be Danielle Weiss from New Hampshire.
All right, great. So as David just said, my name is Danielle Weiss. I manage the Health Professions Data Center in New Hampshire. And today I'm going to talk about the legislative process to collect healthcare workforce data in New Hampshire. So it has been a very long, arduous process getting legislation on requiring our workforce survey, spanning from 2013 up to today, and the discussions and work around implementation are still ongoing, although we are now at the home stretch. So the long and winding road. This process has really put us through the ringer. Between misinformation, high turnover, a reorg at the Division of Health Services, which houses the licensing boards, setbacks from oversight committees, I thought it was only right to set the stage here with the following introduction. Now, we're not quite there yet. While the boards now have statutory authority to require survey completion, we still need to wait for individual board approval of the provider surveys, approval of the one set of administrative rules by each board, and the lengthy rulemaking process to conclude before actual survey implementation. But we are confident that our now required surveys will be implemented within the next 2 years. So just a little bit of background here. The Legislative Commission on Primary Care Workforce Issues statute, which was created way back in 2008, charges the New Hampshire SOAR, the State Office of Rural Health, to collect data on the current and anticipated supply of primary care providers by creating a health professions data center. The Legislative Commission is to use this data in annual reports, and as you can guess, the Commission hasn't been able to do this. Nevertheless, our office, which houses the SOAR, hired me to develop and manage the data center. Again, the goal is to collect supply capacity data on primary care. However, and I'll get to this later, we did expand this goal to include primary care associated providers, such as PTs, OTs, STs, LADACs, just to be more inclusive. Okay, so during the 2013 and 2014 years, we were figuring out, along with the Board of Medicine and the AG's office, whether a survey requirement could be as simple as an administrative rules change, or would it need a statute. The Board of Medicine's executive director at the time believed surveying was authorized under the current rules and that the administrative rules could be updated to include our survey components. This belief was apparently supported by a rep from the AG's office who orally confirmed the board's authority to the director, but of course was never able to put it in writing. So that was our first red flag. That second now dispelled belief was that because the boards and the SOAR are entities under the state government, information could both be collected by and shared with us. But even with this confusion, this time wasn't wasted. So the data center, also known as me, used this time to acquire survey software. We partnered with the Board of Medicine and Provider Association, developed and tested the survey, and focused on notifications to providers, assuming the requirement would be in place by the 2015 renewal cycle. So the Board of Medicine went forward with the rules change, but in 2015, when the rules hit JLCAR, which is an oversight committee, the attorney ruled that the Board of Medicine did not have the authority to require the survey. Basically, they said that it wasn't the intent of the legislature for the boards to modify the rules to collect data as a vehicle for the SOAR to collect this data. But the Legislative Commission on Primary Care Workforce Issues reauthorization bill, HB 483, just so happened to be moving at the same time we heard the JLCAR news. So the chair, a former state rep, asked sponsors for a little more time to add an amendment to authorize the boards to require surveying so the SOAR, us, could collect data and report findings to the commission. So the Board of Nursing, Board of Psychologists, Board of Dental Examiners, and the Board of Mental Health Practice were all presented to within a month's time and all voted at the end of the presentation to support and be included in the legislation. So only a month later, in May, the amendment was rejected at the Senate executive session. The Senate chair also chairs the Executive Departments and Administration Committee, the ED&A, which wasn't informed of the survey or consulted. And honestly, this is understandable because the ED&A's duties include considering matters pertaining to administration of professional licensing. So the chair was concerned that the requirement could prevent license renewal for a fully competent provider. The rejection, however, it came in the form of a rebuke from feeling professionally insulted by the oversight. Before the committee could even weigh in, the chair promised that she would ensure the bill wouldn't pass, got up and left the room. And so after some time passed and apologies were made in person, over the phone and in writing, the senator visited the commission, the Legislative Commission on Primary Care Workforce Issues. So it did seem when she visited that she understood New Hampshire's need for the data and supported our efforts to collect this data during the license renewal cycle by working with the board, but again reiterated that the bill wouldn't pass without an opt-out clause. And during this time, we did gain additional support from legislative commissions. Both the Rural Affairs Commissions and Commission on Healthcare and Community Support Workers recommended standardized required health professions data collection in their annual report, so that helped. Okay, meanwhile, in 2015, the survey was released to physicians as voluntary, but with a warning that it would most likely be required by the close of the cycle. This was before the reauthorization bill hit the Senate executive session. And while we didn't get the requirement, we did get about an 88% response rate. We released workforce data on physicians who renewed in 2015, which you can find on our website. So this was the only time providers believed the survey was a requirement for license renewal, and the high response rate is just a result of that. So because there was no suggestion that the survey would be a requirement in 2016, of course, we only got a 7% response rate. And, you know, of course, this was a huge hit and rendered the data unusable. And even though in 2017 we surveyed the same cohort of physicians surveyed in 2015, this time we only got a 44% response rate. In 2016, the Division of Health Professions had a reorg to bring all of the health professions licensing boards under one central office with one director who luckily supported the initiative right off the bat. With mounting support from external stakeholders, now including the division director, the chair of the commission found a the chair of the Legislative Commission on Primary Care Workforce Issues found a prime sponsor and bipartisan sponsors to support an LSR, which is just a legislative proposal, which began the legislative process for a statute around provider surveying. So the bill, House Bill 322, was created to authorize the Health Professions Board to require survey completion as a part of the renewal process. Okay, so moving on to 2017, we knew that this would be a greater challenge to get the bill passed with a Republican House, Senate, and Governor in New Hampshire now. The real challenge was always gaining approval from that Senate ED&A chair. And the bill passed in the House, but of course when it hit the Senate, the chair needed more assurance that fully capable and competent physicians wouldn't lose their ability to practice from just not completing a survey. So we amended the bill to clarify, under no condition will an incomplete survey prevent physicians from being relicensed. Now, this did cause some confusion among committee members as to what the requirement was. It is a bit contradictory given that the survey is called a requirement, but there is an opt-out loophole. Ultimately, with both sides satisfied and with bipartisan support, it was placed on the consent calendar and passed. So on June 16th of this past year, HB 322 was signed into law, finally. So, end of 2017, where are we now? So, the administrative rules are being crafted by the Division of Health Professions lawyer. One set of rules will be applied to the boards with a formal opt-out option. So, in other words, the rules need to be accepted by every participating board, 8, I believe in total, before we can move forward. So we want the opt-out notification and the renewal packets explaining the opt-out form will be available on the DHHS site, our site, and the board website. But it's to be printed out and mailed to our office. So providers won't be able to simply stick the note in the packet to be returned to the board. This will hopefully deter providers from refusing the survey. The surveys are now online, ready to be tested and approved by the boards before implementation. We are a bit behind schedule, and the chair of the commission and the DHHS legislative team is working to keep things moving forward. The deadline for the draft administrative rules and survey testing by the boards was planned for September when we met with the Division of Health Professions in June. You know, there were pressing legal matters that prevented the division from delivering on time, so that's been pushed back. Our office has spent the last month mobilizing, working with the legislative team and the Legislative Commission on Primary Care Workforce Issues to assist with draft rules where they can and board engagement. The division has decided to propose the draft rules to boards without us now, just to catch up and meet the deadline. And after board approval, they enter the rulemaking process, which allows for public input during 2 opportunities before actually being formally adopted. So there's definitely still work left to be done. Takeaways now and lessons learned. So this is where I think other states could definitely learn from us. Talk to other states, learn from them, learn from us. One of the drivers for legislative change was a document of states with legislation on workforce data collection. I started with our list developed during my first weeks in the office and the TA Center's inventory. I directly contacted states that were listed as having mandatory data collection to understand in what capacity and with what authority they were doing this work. There are Also, many ways to implement data collection. So which one will work for your state? We found that there was no one right way, really. Everyone does it differently, and different data collection methods work for different states. So the entities described in legislation who collect data differ. And David mentioned earlier, you know, it can be licensing boards, state offices, universities, commissions, AHWTACs. Some states require survey completion and the license will not be renewed without doing so. Some allow respondents to select NA or no response. Some mandate a few fields and leave others optional. And then others like ours authorize boards to implement the required survey, but the boards aren't obligated to participate and or offer an opt-out. But with all this, one thing was clear, and that's that all states' data collection efforts are a result of collaboration. So also coordinate efforts with individuals with political clout or standing if you can. We wouldn't have gotten here without the assistance of the Commission Chair and her experience and friends in the legislature. Coordinate with groups with legislative authority to report on workforce data. Again, we had 3 legislative commissions behind us, just as eager for this data to carry out their goals. And finally, involve all of the necessary stakeholders every step of the way. So even if that means you're involving stakeholders you have to compromise with to get to the data, we included provider types that we wouldn't have necessarily brought on board, but the more inclusive, the broader our support base. And don't be like us and forget to include those that have a stake in it, or it will cost you like it did us. And then also initially, we were concerned about the Republican-controlled chambers, but we did realize the increased scrutiny from legislators, while tedious, also meant more comprehensive legislation that covered all of our bases. We initially wanted something short and sweet, but realized we benefited from spelling it out more. So that's really all I have. Here we are after 5 years and within reach of mandatory surveying and collecting this workforce data. But, you know, there is still work to be done, and, you know, obviously we won't rest until it's accomplished.
Thank you, Danielle. We do have one question from the audience, so let's go ahead and take the question before we move on to Mary Lou. I believe we have plenty of time. The question is, are your surveys based on the MDS, that is the minimum data set? Are they fairly similar in what they ask?
They are. So we actually use the MDS sort of as a backbone or a template to develop our surveys. That was definitely our starting point. Then after we did that, we also got input, you know, from other associations and entities, stakeholders. And I'll just give the Board of Medicine physician survey as an example. We got input from and crafted the survey from the Medical Society input and the Office of Minority Health and Refugee Affairs and the New Hampshire Recruitment Center and, of course, the Legislative Commission on Primary Care Workforce Issues. So I think it is a really good starting point, but of course, you know, I think that it can also, there can be additions and modifications to it depending on, you know, what your stakeholders want to see and what you need to work with, especially if some of you are in the primary care office for shortage designation.
Okay, thank you. Well, let's move on to our next presentation.
Thank you very much, David.
Yep.
I was asked to give a brief discussion about how we have been evolving in the state of Florida from the Florida Center for Nursing to the point where we are actually introducing Healthcare Workforce Research Initiative in 2018. And the process that we've gone through to go from being focused solely on nursing workforce data to being focused on all health occupations data. So the Center for Nursing was established in Florida in 2001 in statute, so we exist in law. Our purpose is to address issues related to nursing shortage, and our obligations are to the people of Florida. The vision for the center is to be the definitive source of information, research, and strategies addressing the dynamic nurse workforce needs in Florida. We work on gathering information from all three of the areas of what we call the nurse data trifecta. Nurse supply data, we have a cooperative relationship and collaborative relationship with the Department of Health and the Medical Quality Assurance, who oversees the collection of data and the renewal cycles for the licensed practitioners. So since 2007, we have included the survey for LPNs, RNs, and advanced practice registered nurses within the license renewal process. It is voluntary, and it is their ability to renew isn't dependent upon completion of those data. However, we have a very good participation rate, and so we've had an excellent opportunity to collect data. We have revised our data sets on at least three occasions. One, when we first went from what was our basic collection to the first minimum data sets that were established by the National Forum of State Nursing Workforce Centers. And then again, just recently, we're in the process of revising it to reflect the updated minimum data set, which was just published in, I think, 2016 on the National Forum. And we also are adding some new questions related to try to have better clarity about our ethnic and the diversity of our nursing population. Our nurse demand data is collected also through a voluntary process. Until this current year, we were collecting it in a paper and pencil type survey and mailing out copies to, well, nearly 4,000 employers in the state of Florida. We initially, in 2007, had a decent response rate of nearly 40%, certainly greater in some industries and not as great in others. But that has, since around 2011, that we collect this every other year in the odd years, the response rates have been dwindling. We did try this year to collect it as a electronic format, and our challenge there is that we don't have good access to email addresses and contact information. So it's a very intensive process. We actually stopped the survey mid-collection and because of the low participation rates, and have decided that in 2018 we're simply going to go forward with a randomized sampling approach to try to gather our demand data. This, again, has been done every 2 years, and we've collected for hospitals, psychiatric hospitals, home health agencies, hospices, skilled nursing facilities, and public health departments. The nursing education data is collected also on an annual basis, and until this year it has been on a voluntary basis. As of this past legislative session, that it was set that there is a requirement for all education programs to participate in the survey, although I will say there is not any, there's the carrot but not the stick, if you will, then really nothing happens if they don't. So we had a very good participation rate. I don't want to make it sound like we didn't receive a lot of good data, because we did. However, it wasn't 100%, and there isn't anything that we can do to really enforce that. And that is on the RNs, LPNs, associate degree, baccalaureate, and higher education programs. What we've done as the Center for Nursing has been in existence over time has really been able to demonstrate our value. We've received good recognition on the quality of the data that we report. We've demonstrated the ability to provide trends and forecasting. And we've published our information at a statewide and regional levels. We found that the availability of the regional data is extremely popular with our users of our information. We frequently provide testimony for the Florida legislature. Our data is utilized by the legislators and staff to justify proposed legislation, and by industry and academia for planning and grant applications. Our data is also available to the public, and we did a brief, sign-in before you can look at our reports for about 3 months, and we're surprised by the amount of use by venture capitalists. So that was an interesting find. So that led us to the opportunity to work with the Workforce Investment Board of the state of Florida, which is known as CareerSource Florida. I had had the opportunity to serve on that board at the state level for about 6 years. During that time, I spent a fair amount of effort in trying to help them see the value of the health industry to the state's economy, as well as to the benefit of being able to recruit other businesses and retain businesses in the state by having a strong healthcare system. Prior to that bit of a transition, there had not been much emphasis placed on the healthcare workforce for the state of Florida. After I completed my terms on the board, I was invited to submit an application for funding to establish the Florida Healthcare Workforce Initiative, and it was funded through CareerSource Florida for a 3-year period. We're ending our 3rd year this month. That project was led by high-level health industry leaders who served as the steering committee that directs the initiative, and the purpose of the project was to develop recommendations for statewide policy that would facilitate a sufficient supply of highly skilled talent to meet the demand of Florida's current and future healthcare workforce needs. In other words, this was an industry-driven project where we brought leaders from across the industry for healthcare and asked them what their challenges were, what their needs were, and what they saw as their future. Given our difficulty in collecting demand data, this was a way of trying to also get engaged with leadership from the industry and be able to help learn more about their challenges and interests. For our data collection strategy, we worked to identify gaps in healthcare workforce supply and demand data and designed a collection system to effectively manage that data at the state and regional level. We had the fortunate ability to utilize a report that had been done by the state university system the year prior to our beginning this project, which was a gap analysis that they had conducted. And we really only had to refine it to increase it beyond just baccalaureate and higher program information. And so that provided us a nice foundation for some of our effort to look at find the gaps. We also then provided direction to the state of Florida regarding the assurance. We provide direction to the state of Florida regarding assurance of an adequate healthcare workforce. Once the leadership of the industry, various industries, saw the data that we have for nursing in the state of Florida, there fairly quickly became the desire for them to have data on all health occupations. So we initiated, again, through the Department of Health Medical Quality Assurance. The relationship continued to evolve from just nursing collection to actually collecting on other health occupations. So this just gives you an idea of how we started in 2017 and into the first months of 2018. Like nursing, we collect the data at the time of the license renewal and on the renewal cycles, and then we will be receiving this data from the MQA and have the ability to provide reports out on these levels of occupation. The most significant outcome of this project, though, in my opinion, is the establishment of the Healthcare Workforce Research Initiative. And the foundation of the research initiative builds on the expertise and successful data analysis model of the Florida Center for Nursing. So during this last year of effort with the healthcare workforce leaders, we asked if they wanted to see this type of work continue and progress and how they thought that that should occur. And they're very supportive of the concept of having a center, albeit in this case using the term initiative, designed much like the Center for Nursing. So we have and will be establishing, we are currently housed, if I haven't mentioned that before, I want to recognize the University of Central Florida because they may not provide us funds, but they provide us in-kind contributions that are very important, such as space and the ability to use their human resources in finance and accounting. So we will continue to be located at the University of Central Florida, though we will have a statewide focus as we do for the Center for Nursing. And the research initiatives funding partners, at least initially, are Florida Blue Foundation and CareerSource Florida. Our work is to solve the workforce issues for the health of Florida. So the purpose of the initiative is to serve as the organizational nucleus of healthcare occupations data, to support informed decision-making by healthcare stakeholders, and to facilitate research and grant proposals that support a healthier Florida. And this is what it looks like. The intent is to retain the Florida Center for Nursing as it is, in the sense that I've said it had been established in statute, it exists in law, and so we don't want to change that. Then we will add to that center the other two centers, first adding a Center for Allied Health Professions, and then later a Center for Healthcare Providers. Obviously, the shared services around the outer middle circle are intended to be supportive and therefore not requiring each of the centers to develop their own, for example, research and analytics team or marketing and communication strategies. We're excited to be on the road to establishing this effort. We will be, I'm already in the process of collecting information, as I shared, on health occupations. We are also having some conversations with the legislature about requiring the Agency for Healthcare Administration in Florida, which is the licensing agency for the healthcare industries, requiring them to collect some data on workforce as a part of that license renewal process. So the same model that we use for the professionals, to apply that to industry. We're not sure where that will go. I think that there will be some pushback because there is certainly concern on the part of our industry partners that a given facility would be concerned that perhaps their own situation as far as numbers of vacancies or something might be reported. We are making a commitment in both the proposed statutory language, but just in practice that as with the supply data, we report it simply in the aggregate. We do not report it at an individual nurse or, in this case, an individual facility level. We will, in time, as we truly bring about the existence of 2 to 3 of the centers, we'll probably change our status to that of an institute, which then brings with it, at least in the state of Florida, some additional benefits. And this first year, we're looking at funding through sponsorships, grants, and other donation services. We are going to engage our industry partners, especially those who are funders, and then those who have been a part of the workforce effort over the last 3 years, to continue as an advisory panel, and with a charge for the first year to develop the sustainability model. There are a lot of options as to what that could look like. One is that it could be a public-private partnership, which would then bring in some state money, but also retain an industry commitment to funding as well as participation in the oversight of the entity. It could be that we become a membership entity where we no longer provide our data and information free to anyone, and it is simply either a member benefit or perhaps available on a menu of items that could be purchased or for a special project consultation. And actually the consultation component is something that we feel will be an advantage to offer through this model, no matter which funding source we have. We work with several large hospital systems, for example, here in the state of Florida, and we believe that there are interest from those systems to have us, for example, provide them a very personalized report on their own facilities, including other facilities even in their regions. And that concludes my presentation. There's some links for some of our available information from the website and my contact information. Appreciated this effort and the opportunity to participate. And we're very excited about the opportunity to expand our work here in Florida and moving forward to having information about the entirety of the health occupation team. We believe that it is a team effort and that we can best design and utilize good healthcare delivery systems by understanding each of the team members and their roles and capacity. So thank you very much.
Thank you, Mary Lou. And at this point in time, we'll go ahead and move into the Q&A segment. And just a reminder to the audience, you may use the chat panel on your screen to ask questions of our presenters. With that said, Mary Lou, I actually have a quick question for you. Well, maybe not so quick, but what was the biggest challenge to establishing the Health Workforce Research Initiative?
Well, the challenge was taking the time to develop the relationships and the support of industry. That was one thing. It was not something, it took nearly the full 3 years to get to the point where we felt there was a commitment and a strong interest in moving forward with this. Then in the academic model, as I said, we're still a part of the University of Central Florida, and as many of you work within university settings. There's also a bit of we are not a typical academic center or an academic model. We are different, and so there can be a challenge in helping leadership within the industry, within the university, to really understand and see the value of what it is that we offer that can, in fact, be very beneficial to our colleagues in the on the academic side of the university.
Okay, thank you. And just really a quick follow-up to that, was there a particular action that you really think helped achieve this goal?
Well, one thing we did, we held a summit I guess it's been a year ago, and it was held in partnership with the Florida Chamber Foundation. And what was interesting to me is that a surprising number of healthcare industry leaders had never been engaged with the Chamber or, understood what exactly the Chamber does. And we've worked with the Chamber for a while in looking at how we can help promote business and so forth. And so we did that, and at the same time, as a part of that summit, we brought in representatives from across the state, the United States, from the state of Washington, we had Jean Moore from New York, and from Utah, and we had a panel that talked about other ways that one could go about obtaining data and information on other than just any one health profession. And I think that demonstrating the activities that are taking place in other areas of the country and the successes that they're having was very positive as well. But I think that the majority was getting out there, and we have established as a part of this project, over the last 3 years, we not only had a statewide effort, but we had regional efforts. So we had 6 groups around the state that were active also during the 3 years, and bringing people into those. Florida's we're the 3rd most populous state now, and we're geographically very diverse. And I think helping people see that there was interest in their challenges and their positions in different areas of the state, rural versus urban, northwest versus southwest, southeast, also was a positive activity to help bring forward some support.
All right, thank you, Mary Lou. And for the next question, well, I really think y'all can both answer it. So perhaps, Danielle, we can start with you, and then Mary Lou, you can chime in. But has there been any pushback from health professions regarding survey completion, and have any professions been more problematic than others?
So even though, this is Danielle, we have begun partnering with the other licensing boards, we really had more experience with physicians and the Board of Medicine. So we haven't really had the opportunity to work with other provider types besides physicians. And I can't really say now whether we'll encounter some pushback when we get there, but from my experience with physicians, there really hasn't been any. The handful of physicians that weren't thrilled to take the survey, it was really because they didn't want another thing to do for renewal. They have a lot on their plate as it is, and it was just another task. And a couple of physicians questioned our need for the data, and they sort of assumed the board or other organizations have it. But once I explained the need and that we don't have it elsewhere, they definitely came around.
Well, it's interesting because in Florida, the only group that is mandated to provide supply data is the physician population. So there is already data collected during the license renewal process that the Department of Health has and, you know, occasionally provides reports out of. I have to say there's been some inconsistency in the analysis of the data, not inconsistent results, but I mean in just the fact of the analysis taking place and the information being published. But so it is already mandated for physician groups. Other occupations are very anxious for the data and the information. I think we're going to have to do some communication and help the members of those occupations understand more about what we're doing and why. But we had, as a part of this 3-year project, we had an advisory group that was comprised of leadership from the professional associations and trade groups for all the health occupations, at least everybody that we could gather together. And they're anxious to have better data about their own occupations and workforce. So I think that I don't think that will be an issue. Again, if I were to have said who do I think there would be a problem with it, it might have been the physician group, but they're already in a position of having to provide the data. So and we are going to work on a relationship with to continue our relationship with the Department of Health to be able to obtain that data to use as we look at in ways that it might be helpful to have that as a part of a report regarding all occupations.
All right, thank you. Do either of you plan to use the data you're collecting for HIPS analysis?
Had not thought about that, so I would have to say not at present.
This is Danielle, and that was actually definitely one of our main drivers to collect this data. You know, we house the PCO. I work in the primary care office. So this data is especially key because of our work to identify and process shortage designations in the state. And honestly, without that data, we can't really do so, and we can't do so accurately and with current data. So we definitely needed, you know, where the providers are, the provider hours, specialties, in order to do our work. So yes.
Okay, thank you. And really, as kind of a follow-up, beyond HIPS analysis, what type of research agenda do you have in mind for using this data?
Can you clarify?
How do you want to use this data beyond, say, for HIPS analysis?
So we want to be able to use this data not just to sort of issue out these, you know, provider briefs and to just, you know, give the public a better idea about the physician landscape, but also our stakeholders too. You know, the recruitment center and those legislative commissions I was talking about earlier, they need this data to do their work. So we want to be able to, you know, as Vermont does, like put out these provider reports to inform, you know, again, not just the public, but stakeholders who really depend on it and need it to do their work.
And I agree with Diane there. And but in addition, we are hoping that we will be able to begin to really influence evaluation of new care delivery models. I think that there are opportunities in inpatient, outpatient, and all settings to really look at I mentioned the team before. I think we really need to start to look at the team. I'm concerned no matter, you know, what, I know we have lots of varying reports saying whether or not we're going to have a shortage by 2050, but I just am concerned personally that I believe we will. I think that we are going to, as we age out our nurses and age the population, the demand and the supply are just going to continue to go apart, and that I'm not sure we can actually ever really prepare enough nurses, for example, registered nurses. So what do we do as new models of care? And we talk about that we need new models, and I just think that it would be good to incorporate the workforce team and consideration of those models. For example, physical therapy assistant. Now, at least to my understanding, the majority of the time, the physical therapy assistants really work in concert with physical therapists. So therefore, there has to be an order and a method of reimbursement in order for them to be interacting with clients. Why not have physical therapy assistants assigned to areas of the hospital where they actually then assist the nursing staff and in ambulating and positioning and the physical movements of patients, thus using people who are more able to demonstrate good body mechanics for themselves as well as for working with the patients and utilizing someone with their skills and training that could then relieve some of the pressure of work and such on the nursing population.
Thank you. Do either of you plan to make data available to researchers looking for record-level data for analysis?
Absolutely. That's something in the state that we've already had requests to do. And of course, you know, this data is protected and confidential, but you know, it can be aggregated, it can be de-identified to share that data for research purposes. I think that that's exciting also to sort of, you know, discover, and we may do this with an intern, you know, the disparities between rural and non-rural, like really look at the nitty-gritty in the data, be able to parse it out more. So I think that's definitely something exciting that can come from this initiative. And I think we're able to still protect the data, but share it with others to better inform, again, you know, researchers and stakeholders and the like.
And I would hope that we could do so as well. I think what's going to determine that for us is how we're funded. You know, whether we need to consider the data as the value that we can, in fact, you know, seek funding in order to be able to continue the work. I hope that's not the case. As I said, my hope is that this could be something that's available to more fully utilize.
Okay, and next is really a quick question for myself. How do you keep the data collection inventory updated? Well, it's by all means a work in progress, as the data collection inventory itself is a work in progress. That is, I suspect there's still organizations out there that are collecting data that we aren't aware of. Now, as far as keeping the information in the inventory itself updated, well, we do regular follow-ups. At least once a year, we reach out to those individuals who are already in the inventory and ask them to update their information. And of course, inevitably, there's some bad email addresses which we have to do some follow-up on. So that's also a work in progress, but it's something we're committed to, and we plan to keep doing the inventory for the foreseeable future. One more question. Danielle, what will the licensing board's role be relative to data collection for you?
So it was always important to us to assure the boards that their administrative role in this would be minimal. We really don't want them to be burdened with this initiative, as, you know, they're already short-staffed and inundated with work. So what we'll do is I will have documentation on who has completed the survey and opted out, and share the updated list with the boards at the end of the day or at whatever interval of their choosing. They will need to refer to the list before renewing the license. And then also it's likely that although we're you know, clear in all communication to providers to contact me regarding the survey, you know, it's likely that providers will contact their boards, you know, skip over that and just go for what they know. The boards will then need to provide TA or refer them to me. So, you know, this is the extent of the board's administrative role, and even though I'd like to say there is no additional work for them, or no work at all for them, I think that we made the work as minimal as possible.
Okay, thank you, Danielle. We're getting close to the end of our event, so let's just try to wrap up with a final question. And Mary Lou, I think this is more geared towards you. I know you discussed it a little bit towards the end of your presentation, but perhaps you could elaborate, and if Danielle, if you could chime in here too, I think that would also be useful. But what is the sustainability plan for this work?
Well, as I said, we have been testing out some models and getting some, responses to people. Right now, for year one, we're going to be doing seeking sponsorships and grants, and we already have some, promising opportunities there. But in the long term, it's going to have to be something that is more of either the public-private partnership or a membership-driven. And if people value the work and need the work, then I think we should be able to keep it sustained. It just won't be the public availability. I don't see, at least in the state of Florida, I don't see the state fully paying. I think that if we demonstrated industry's participation, I think we could achieve a shared sustainability. The public-private partnership would give us more of an opportunity to allow the data to be used by others, as opposed to the membership-driven, which would probably be more restrictive on others' use.
And so for New Hampshire, we think it's sustainable, well, primarily because we were waiting on that legislation, right? So now that the boards have the authority, we're able to collect that data. It's just another piece in the renewal process. They all just got online this year, believe it or not. Many were on paper, most were on paper. So that will make the process a little bit easier. They sort of, just click this quick survey. Our surveys are all hosted by Qualtrics, just a survey, online survey platform. And then the data also is held there. And we download it and we analyze it that way. Luckily, New Hampshire is a small state, so even though I was talking about all of those provider types, we're really talking, really no more than 15,000 total. And, that does sound like a lot, and I think it will be challenging at first, but luckily we are sort of taking it provider type by provider type. I think, we do need additional funding to have our Dream Workforce Center. As of now, we can release reports and issue briefs and inform our stakeholders where we need to and do shortage designation work with this data. And that was really the drive anyway. So, I think it's sustainable, but could it be improved with funding? Yes, of course, but we're short-staffed and underfunded, as most, state entities are. And, we're gonna work with it as we can and do what we can with it.
All right. Well, thank you. Thank you both, Danielle and Mary Lou. We're right at the top of the hour, so I guess we'll go ahead and end today's event. So once more, thank you for the wonderful presentations. And for those of you in the audience, thank you for attending our webinar. We hope to see you again in the future. Have a good afternoon.